Welcome everybody to the October National Urban League Health Equity webinar series. As many of you know, my name is Lydia. I am the Vice President of Health Equity and Policy at the National Urban League, and we run this monthly, almost monthly, 10 times a year, webinar series on pertinent topics that's involving our communities and the Urban League movement. And so we are so excited today to have two wonderful, just brilliant scholars in this field who are here to talk to us about substance use, programs that we can think about in the community, how we can help family members, community members, friends, if they're having issues, what we need to do, and just have a conversation about its impact on our communities, how in this current environment we make sure that we take care of our communities who are suffering from any kind of substance use issues, and just think about what are the best ways to support people when they're having substance use issues. So with me today is Dr. Andre Johnson, who is from Detroit, so I'm going to D, and Dr. Kimá Joy Taylor. I'm going to let them introduce themselves and tell them a little bit about the programs that they have done and run, and then we're getting to the questions. Dr. Johnson, I'm going to start with you.
Okay, sure. Thank you so much, Lydia, for inviting me to be on the show with you all today. And I'm looking forward to learning more about some of the amazing work that Dr. Taylor has been doing. As I said, my name is Andre Johnson. I'm a person in long-term recovery. And what that means is I haven't used drugs or alcohol in the last over 36 and a half years. I got sober in July 13th, 1988. And that's important because my journey has really contributed to me wanting to do this kind of work in this space for obvious reasons, personal and professional. I'm a native Detroiter. I founded a organization 21 years ago called the Detroit Recovery Project. And this organization, we're a full-blown behavioral health organization that provides both behavioral health and primary health care services to individuals who need us. We provide a combination of mental health services, substance use disorder services. We have a team of master level therapists and psychologists and psychiatrists, medical doctors, as well as nurse practitioners. And we provide prevention services as well. We provide mobile outreach and services as well. We have people with lived experience that's part of our team that's going out in the mobile vehicles, along with the nurse practitioner and a social worker, case manager, and engage people who are actively using IV drug use, engaging sex workers in the community, targeting the areas in Detroit that we have the spikes in terms of overdose deaths. So we're trying to mitigate overdose deaths here in Michigan, and I hear across the country overdose deaths have decreased among whites and it's increased among blacks. And so it's really making a difference in what we call a marginalized community. Personally, I got my bachelor's degree in psychology from Morehouse College shortly after my sobriety, and later went back to school and got my master's and my doctoral degree in psychology as well. And so I really wanted to understand mental health. I wanted to understand trauma, and I wanted to understand these things so that I can be an asset to our community, but also be an asset to the agency that I founded 21 years ago. We have about 60 employees that work full-time on a day-to-day basis. We have two centers. We've been recognized by President Obama for some of the work that we've done. I received the Champion of Change Award, and we've done quite a bit of work in this space to make a difference in our community. So again, thank you again.
Fantastic. Dr. Taylor.
Sure. Thanks for inviting me. And it is an honor to be on a panel with you, Dr. Johnson. My name's Kimá Taylor. I'm a pediatrician by training. Originally worked in a federally qualified health center in Washington, D.C. And I would say that I approach this topic from two spaces. First, really around First, is the services, but also a lot of policy. Reason being, when I first started seeing patients, there was, for my parents and their kids, it was clear who was having their babies taken away and who wasn't. Who was
Mm,
having their babies taken away with no access to services, though they said services were the way that they could keep their families preserved, and who wasn't. And the randomness in who's tested, who's all of those things. And so really, start out seeing patients. How do you think about keeping families together, and particularly families of color, right? We don't have to play any reindeer games on this call because anyway. But and so really looking at, and it became clear, like you'd see one patient, you'd be really a good advocate for them, and then the next one come in. You're really good advocate for them, the next one came in. And so then I was like, I have to do policy. Like, and I'm gonna go through some phases where you see how naive I am. But I was like, I want to go back to school, understand the policy, understand how we got there, because it's clear the policymakers just don't understand. And if they understood, if I could use their language so they understood, then they would care. So I say I
mm.
was naive. Went back to school. That's where I was honored enough to meet Lydia. Came out, and I went back to school on a scholarship, which I was very lucky to get because I had $1 jillion worth of loans. And I will say the other important piece, which Andre kind of alluded to, it was because it was when I saw patients, they're mostly black and brown. Literally, probably saw like 4 white patients, and they were from Bosnia. So it was like looking at yourself in the mirror and like, why I can't be a part of our community, always not. And so wanted to figure out how do we change that dynamic, and not like, the Nina Simone song, you don't have to sit next to me, I just want my equality. Like, I don't need to be best friends with you, but we do deserve to have access to the services that allow us and our communities to thrive. Went back to school, and I'll spare you the long story. I'll get to the long story short around this particular work because I went and worked in the Hill. They know, they don't care. And I think that's really important is Dr. Johnson was talking about overdose deaths going up with Black people, because I assure you, when this opioid crisis came, we said Black people were going to die. No one cared because we weren't entering through the prescription drug route, right? Because we didn't have insurance. There's many reasons we did not enter in that route, but we still had substance use. But you still had the marginalization of people who use prescription drugs versus people who used heroin and other drugs. And so it's not surprising there's higher rates of overdose now because they don't care. And I think that's an important thing for us to keep in mind, because in talking of the services, we also have to talk about how we, again, you don't need to care, but you need to fund the services in a way that's going to keep them sustainable and keep our communities alive. Went from there, went to Baltimore City as deputy health commissioner. And that was many years ago, prior to this opioid epidemic. And there we already had syringe exchange. We had an access to naloxone, even a standing order till it was deemed illegal. Had methadone clinics that had gone through, the community had gone through the NIMBY process to say this is why you need to have methadone clinics in your neighborhood. And that piece around that we don't talk about, um, the willingness of government to put services in certain areas, and this is really important for this opioid crisis as it changed, and not willingness to put it other places, and community being like, dude, well, what about our housing crisis and other things? And like, unless you have really, unless you include community in what you're doing and have these really honest conversations about what people need, the pros and cons, like, it's not going to sustain, right? It's not going to work. And so in Baltimore, the number one reason for our HIV crisis was IV drug use. And that is why there was this need to really make sure that we had these services: prevention, harm reduction, treatment, medication for opioid use disorder, recovery services, housing, all of the other things that are about health, not just healthcare, because folks wanted the HIV rate to decrease. And they wanted the HIV rate to decrease, let's be honest, because it cost a lot of money. And they could no longer get away with, if we don't say anything, people just die and that'll be cheaper, right? They couldn't play that game. So it's like, what can we do? But ultimately, again, engaging community, it's like, what can we do so folks can thrive? And so I really want to, like, a big piece of the work I would love to see moving forward is how we have those honest conversations in our communities. Because on the flip side, it's really hard when your family member uses services for myriad reasons. One, there's no access to useful care often. Second, you're often ostracized, right? If you're the parent, it's your fault, and so no one wants to talk to you. If you're the person using drugs, people are ostracizing you. So there's not that support. And we don't like to have those conversations. And you can be mad at, like, we get mad at family all the time. You can be mad at someone, but if you're mad at the person with diabetes, there are these support systems that that will still get access to care and everything else. If you're mad at their loved one who uses drugs, you're screwed, because if you don't have a navigator, that issue's hard. And that gets me to the second part of my job. So I went from health department and worked in a foundation. In both those spaces, like, how do you pull this out of the punitive system? Right? Our response is, you use drugs, so we're going to put you in jail. We're going to take your child away. We're going to do all these, we're going to remove you from school. We're going to put you in the school to prison pipeline. All these things that harm and ensure we can't thrive. And so, how do you put in place, pull people out of punitive systems and offer the supports they need? Sometimes that's treatment, sometimes it's harm reduction. We always have this vision that everyone who uses drugs has chaotic drug use. You know, a lot of the, like, look at alcohol. People are functioning. Yes, they're using drugs, but they're functioning. So do we need to then take that functioning away and put people in prison and ensure that they can't thrive? Because it's not just that. There's always these studies that services in community are better than services in prison. And you're like, you spent money on that? One, there were no service. Of course, it's going to be better. There were no services in prison. They certainly weren't culturally effective services in prison. And even that act of putting people in prison, they now, when they come out, have all these collateral consequences, because regardless, honestly, of cultures, we do not like people who use drugs. So we take away housing after you've been in prison. We take away access to many drugs, particularly in healthcare, which is actually the services that's supposed to be helping people. And as a pediatrician, separating family. Yes, child abuse happens. I am not saying that it doesn't. But substance use and a urine drug test is not a test for parenting ability. It's not a test for whether you're abusing someone, and it is certainly, funnily enough, not actually a test for substance use disorder. And so we have to stop hanging on to these pieces and realize that often keeping people together and offering people, I don't care who you are, parenting is hard. So offering people the supports they need to parent in the best way possible is much better than having child welfare engage child welfare, who also does not have access to any of these culturally effective services, having them enter and vive and tear families apart. At least, like, give it to grandma or someone else who's left, right? And so a lot of my work now is really focused on that pregnant and parenting people who use drugs and family preservation. It is focused on expanding access to and payment for harm reduction. I do consulting now. I also do some research, but I also have a nonprofit that's around that pregnant and parenting people who use drugs. Like, how can we change the conversation that it's the pregnant people who use drugs to how do we actually help families thrive? We are in the midst of maternal child health epidemic. Like, just dying regardless of what you use. Add on substance use, add on the fact that behavioral health is the number one cause for maternal death. Like, stop picking things apart. How do we really create and change the conversation so that we have parent infant dyad thriving in the supports they need, so that we can have all those voices, wonderful brains, tons of love in the community to help us grow? And so that's kind of where I sit my space now.
Well, I love it because we just got in both of your introductions a whole bunch of stuff that I wanted to talk about, but I do want to tear them apart because I think for this group, we need to do things like define what substance abuse, misuse is. What are the terms we're using now? Because I know when I was studying it, we called it abuse. Now we're calling it misuse now. So I want us to get the terms right. Well, I want to talk about what harm reduction actually is and what it isn't, what treatment is and what it isn't. And then let's start with that, and then we'll get into because I think Kimá, you make some really good points that Andre can talk about the community supports that are needed to support a family and a person who is going through this. So let's start with how do we define substance use, misuse, abuse, and even also define the term behavioral health, because is it the same as mental health? Some people use behavioral health, some people use mental health. Let's get it clear for everybody here so that they know when they are accessing these services what it means. Andre, I'm going to start with you.
Sure. So behavioral health, in the context that we use it in these days, are often it's an overarching theme. And under behavioral health, there's two components, which is either mental health and or substance use disorders. So the up-to-date term is like substance use disorder. And we know these terminologies continue to evolve and change because people say they have all these negative connotations. And so substance use disorder is the term that is inside of the DSM-5 book, that is the book, the Diagnostic Statistical Manual that describes a myriad of illnesses, mostly mental health illnesses as well as other illnesses. So everything kind of falls under that umbrella of behavioral health care. And the field has started to shift over the last few years and be more integrative, which I'm really happy you have Dr. Taylor on board, because she's the first pediatrician with an MPH background that I've heard describe just the amazing work and knowledge that she's doing. But that's what it's now about, integrating both behavioral health and physical health services, because the people who've been using drugs, we also know that they have what's known as comorbidity or co-occurring. So co-occurring is when they have the substance use disorder and or mental health illness, and then comorbidity is when they have those illnesses as well as physical health illnesses like diabetes, high blood pressure, hypertension, and all those type of things. And so, and we know that, Baltimore has a very similar demographic to Detroit. And we both have always shared information and looked at each other's models. And in Detroit, you have these high social determinants of health. But Lydia, you brought up a good thing in terms of what does this language mean? Well, how's the context? Like right now, under this new administration, the word mobile or harm reduction is not a favorable term to use. And so I think what we've used in place of that has been we're doing mobile outreach, which is the same word. We're trying to reduce overdose deaths. We're trying to, because you can't save dead people. And so we know that people are still dying in the Black community from IV drug use. We know that HIV is still prevalent in the Black community and it's still growing. We also know that hepatitis C is still growing in the Black community where drug use is occurring. And so for us is how do we mitigate those deaths as well as prevent if possible. And I think that's where the mobile outreach initiatives come in at.
So, Kim, can you talk a little bit about traditionally what harm reduction meant, like what
Yeah.
it means? Talk about naloxone. I think it's important, particularly as an MD, for you to talk about what Baltimore, because I know New York City did the same thing with having a standing order. So talk up, because when you said that, I think that's really important for people to know what naloxone does and what a standing order for naloxone means in certain cities. And then talk about treatment, because I think sometimes people think you can't treat substance use disorder. And so talk about what treatment is and what is that like and why is it so important for people to understand
Sure.
those things.
I do want to say just one thing around the language conversation, that I'm stealing Dr. Johnson's mobile outreach because that harm reduction, like having done it so long, I'm like, and people are being taken out because of it. I'm like, what words can we've been playing with things? So I just want to let you know I'm stealing it. Things no, because that's perfect. So for harm reduction, I think the important thing for me about I have a very expansive definition of harm reduction on purpose, because similar to that mobile outreach, I want folks to pay for all the things people need. But in reality, harm reduction really came from community. And this is really important. And it's partly why we also where we are today. I mean, there have been myriad substance use epidemics. But when it came to substance use epidemics around HIV, this is going to sound familiar. The government hated people who got HIV, right? It wasn't like, oh, act like they actually were punitive. Let's not find cures. Let's not treat people. We use this stigma. That is not, we discriminated. We were racist. And so the community said, we got to take care of our own. We got to figure out, okay, let's exchange syringes, clean syringes, so that we don't spread HIV, so our own don't die. Let's provide hospice services, because back then, I was in residency, like people act like HIV is this, AIDS was a horrible way to die. And it was horrible because there were no supports. I mean, people were starving to death. They couldn't breathe. They had cancer, and the government's like, dude, just completely ignored. People have to like actively try to harm people. And so I think that's important because it really, again, says we have to listen to community. Community's like, we got to save ourselves. We are going to create syringe exchange so we decrease the rates of HIV. In Baltimore, before my time, Mayor Schmoke and Pete Billinson were like, we need to have a syringe exchange to decrease the rates of HIV. And if it doesn't work, you can fire us. But of course, it did work. Of course, Kurt Schmoke, as a Black man, still had his political career crushed. Um, but they said we want a public health approach. So it really is community saving one zone. That gets to naloxone. Again, as Dr. Johnson said, you can't do anything if someone's dead. Right? Naloxone is the most benign drug in the world. It is really harmless if you do not have an overdose. You and I could take it 3, 4, nothing would happen. But if you have an overdose, you save a life. If someone is having an opioid overdose and you injection, now they have inhalers. If you give that naloxone, they literally wake up. Now, a few cautionary tales with that. Um, you give it in my opinion, harm reduction is you give it to anyone who's needed. We have found cities that are like, yeah, I give them naloxone once and then they should just stop. So I'm not giving it anymore, right? There's still policy and politics that come along with that where race is included. Can you get naloxone? So standing order, originally for most drugs, I would see Lydia in my office. I'm like, you need this, I'll write you a prescription. That should still happen. I want to be clear. If anyone, one, is being prescribed opioids for pain, and that's another piece. Black people are not prescribed pain medicine, so they still should get it for pain. Get naloxone or overdose. Anyone who comes in your office and you've done a verbal screen and they're using opioids of any type, give them a prescription for naloxone. This does not happen. I am a primary care doc. I can admit this does not happen. So in lieu of that, though we still have to push for that. Standing order means anyone who needs it can go get it. You can get it at any pharmacy. Many health departments allow you to just order or have it sent to you. I don't want to, even though you can get it at every pharmacy, not every pharmacy carries it. And it's usually along the same lines of why or why not, because they want to be paid for it. Right. And so but theoretically, anyone who needs it can get it. It is on a lot of the mobile outreach teams. See how I stole that? It is a lot of the mobile outreach teams because that's who they're seeing. And the point is, I don't just want to give it to Lydia. I want to give it to anyone in Lydia's circle. Because if Lydia's overdosed, she's not using naloxone. I need all the people that she may use with to have the naloxone. So it really should be given out like water, in my opinion. And again, because it's not actually harmful for anything else, so why not? And that gets us to treatment. When I think of substance use, it is a continuum. A continuum on the front end, we often forget prevention and harm reduction. And as a pediatrician, I want to be clear prevention is not a DARE program, right? So we need to do better on that. But prevention, harm reduction, and then formal or informal treatment. And I say it that way because it's kind of like diabetes. In some instances, not everyone is going to want or need formal treatment. Some people may go into Narcotics Anonymous or Alcohol Anonymous, they may have counseling. But really, the gold standard we often say for opioid use disorder is medications for opioid use disorder. Methadone has been around for ages. It is recommended not just for folks who use opioid, but pregnant people. Methadone and buprenorphine, pregnant people, that is the gold standard. There's actually more harm if you don't give it and the person keeps using because, as Dr. Johnson talked about, the Hep C, the HIV, the blah, 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 right? Um, the problem in this country, and I do a lot of work on history, but I'm going to spare you the most of it. The problem of this in this country is, again, we didn't like drug users. And we made it about race. And when it became about race and drug users, so Nixon actually supported access to methadone, but he supported it in a kind of hinky way. Like he admitted that they criminalized and had the war on drugs because they didn't like Black people and folks who use marijuana. But he also said, but let's offer methadone in part because of people coming back from Vietnam, but also in part because they wanted to decrease crime, not because they wanted people to be healthy. And so that is a difference in how you incorporate something into a system, which made many systems resistant to using methadone. But really, that should be offered. Instead, what happened is you had these really punitive kind of often boot camp places that would, if you don't, then we will punish. If you don't, then we will punish. And so the thing that scares me a lot about treatment is often people don't know what they deserve for treatment. You deserve something like Dr. Johnson's program. But the government actually will often pay for many of these boot camp places that are getting money and don't have your best interests at mind. And so most treatment really it should have access to medications for opioid use disorder, methadone, buprenorphine, naltrexone, medications for alcohol use disorder, for nicotine use disorder. It should have, as he said, so for me, and this includes harm reduction, a big piece of harm reduction is access to physical health care. We don't give physical health care for people who are actively using drugs for myriad reasons, but that is harm reduction. Here's a surprise. People have high blood pressure, have diabetes, these other physical things that need support and need to be cared for. That is part of harm reduction. That is part of people getting well and thriving. That should be linked to treatment, as Dr. Johnson said, integration. Treatment should also include counseling, not just sitting down talk, but real like motivational interviewing. We are in partnership. Where what is important to you and how can I help you get there? Cognitive behavioral therapy, counseling. I am an outlier in that I truly feel we should probably have mental health counseling when people come out of the womb. But that notwithstanding, it really should have access to mental health services that are culturally and linguistically effective. We know, I sound like doom and gloom, but we do know that a lot of these treatments are not for our community. They're not culturally effective. They're not linguistically effective. So I feel like we have to hold policymakers and healthcare accountable for actually making them effective. Don't give I once went to a counselor who's like, "Well, just make sure you don't have a mammy complex." And I was like, "And we're done." Right? So it's like making actually sure because particularly for youth it can be harmful. And once you've had a harmful mental health encounter, even if you need it, you're not going back. And we've lost something, and you've lost something for the client. So, really, I think reaching out and understanding what treatment is, asking the programs that folks and your loved ones are going into, what are the services you offered? I had a dear friend who put their son into care and this really warm, fuzzy, all of the spa-like things for substance use, but it didn't have any of the evidence informed. Anyways, had drugs sent to their room in this big spa, and the place didn't have Narcan. Needless to say, the person died. So that's not actually, that should not be paid for. That is not a part of our treatment system. And so I hold, I think that, Dr. Johnson talked about the DSM-5 that can give you some indication of what use, misuse, dependence, all those are. But there's less information about what is good treatment in our community. And I think that's where we need to move to have people have the Bill of Rights and demand what they deserve.
So,
Yeah.
Kimá, I think you just led me directly into what I was going to ask Dr. Johnson. Can you talk about what your program offers, how it offers it, how you help someone who comes to your doors or your mobile team reaches out to take the steps they need to get the help they need in whatever way they feel like they need the help. Because we also all know that just because somebody comes to treatment doesn't mean that they're going to automatically, okay, I came to treatment, so tomorrow I stop using substances. No, it's a process. And there's some people who relapse back and there's some people who don't. But everybody deserves, no matter how many times they relapse, to get help. So I would love for you to just really talk about what your program does.
Yeah, absolutely. In fact, I always say you can't take a clean fish and put it in dirty water and expect the fish to stay clean. Um, we know that generally people, what we've learned and what I've learned is people need a strong recovery ecosystem. And that ecosystem helps people to sustain their recovery, but it also addresses emotional, physical, social, and spiritual elements for individuals once they complete treatment. So what happens now is you may go through a 28-day program and it's expected that you stay sober or clean for the rest of your life. And most people, particularly Black people, they go through these programs, they'd have no support upon leaving. And that was really the catalyst for starting the Detroit Recovery Project is to have a community-based organization that can help people the minute they complete their treatment episode. because treatment is just one aspect of recovery. But now recovery is a lifelong journey. And so, in order for people to really embrace and turn that concept into action, they have to be supported in that process. And I really appreciate Dr. Taylor when she talked about and gave the examples of, somebody had diabetes and they relapse eating cookies, they're not shamed. But we're talking about addiction and in the Black community where there's been a historic amount of shame, historic amount of embarrassment, not to mention the intersection that comes along with decriminalization, or shall I say criminalization. I mean, just think 10 years ago, people were being incarcerated for marijuana. Now everybody's smoking it all over the community, and you can buy it anywhere in the community. It's very, very more accessible than it's ever been. It's 10 times more potent than it's ever been. And it's also impacting Black communities where now young Black kids are, oops, I got the wrong cookie and I took it to kindergarten and I shared the cookie with the other kids. So we're talking about, but just getting back on the recovery piece, recovery does not happen in isolation. It happens through a network of relationships and opportunities. And it's important that we have those networks and opportunities that's rooted in principles that empower people. Because again, we're working with people. Okay, now you put these drugs, alcohol down, but you still have these other your living situations not the greatest, your employment situation not the greatest. Perhaps you don't have any formal education or formal training, so you may have to look up. You're 55 and 60 years old making minimum wages. So we're talking about equity and community. We have to have these support systems that support our people. And so for me, it's been my responsibility to really be intentional to make sure that we can support people in their recovery process. And it's not a magic pill. It's not a magic bullet. It takes patience and it takes supporting people again to really overcome the guilt, the shame, and embarrassment. And then obviously that whole process does involve what Dr. Taylor talked about in terms of evidence-based strategies. It takes motivational interviewing. It takes the intentionality that comes along with the peer support model, hiring people with that lived and shared experience and being able to make sure we have this space that's giving people hope. When people don't have hope, you don't have purpose. But when people have hope, they begin to have purpose. When people have support, they begin to believe in themselves. And so it's our responsibility to support people in the community where they live and perhaps help people tap into what I call their inner resiliency. And make sure we have the ancillary services and relationships with employment opportunity, with housing opportunity, educational opportunity, spirituality. We've employed, we're doing yoga, we're doing meditation, we're doing other things. We're trying to be innovative in our approach, ideally to help people along their lifelong recovery journey. Again, I mentioned earlier, I'm a person in long-term recovery, and I'm an active member of 12-step programs, and I've had the pleasure of attending meetings all over the country, right? And whether it's in the hood or whether it's in Silver Spring, Sandy Springs, wherever, where all you rich people live in the East Coast. And the dynamics are always different, and what I mean by that is, my colleagues who've been sober 5 years in the suburbs, they buying a house, remarried, got a car. And then my brother on the east side, Detroit, he's living in mama's basement, the quality of life, he's trying to get this child support thing off his case. He got this, all these barriers. It's barriers and barriers and barriers. And so that's why we created this recovery ecosystem model that can help bridge relationships with other entities to support the whole person. It's a holistic approach.
I love that. And you both mentioned, and I've always known this, but didn't really think about this issue of kind of stigma, punitive nature of, people who, have are substance use. I want to talk about, I'm going to get to the policy side in a minute, but I really want to talk about families. And so what can families do to support a person who they think, because they may not know or know, is suffering from a substance use disorder? What are the kind of things that we need to think about? And maybe it's more about what should we not do. And Kima made a really good point, because we also we don't want to deny that bad things happen sometimes to people who are using substances, right? There are people who do, because of the substances, may abuse their child. There are people who steal from their family. There are people who do things that, your family may not be happy with. But we also know, as we said with other conditions, it is a disease that needs to get treated. And so if we see it that way, even though some of the reactions, or the actions that come with the disease are stuff that really impact families in tremendously difficult ways. How do we support families, right? Spouses, girlfriends, boyfriends, partners, children. We know how it impacts children, particularly, with supporting, or at least helping. The word I'm looking for, because maybe they may not be able to help, but being a system that doesn't make it worse for the person. That's what I'm looking for. Make it worse for the person. So they may not be able to help, but maybe a understanding, maybe that's the word I'm looking for, of the person who's going through substance use issues.
Can I
Absolutely.
start and I'm going to pass it to Dr. Johnson? Because I
Okay.
think this is where no one ever talks about young people, right? And this is where I think that families can really have an impact. And it's hard. Like, we have to admit that it's hard, but you got to talk to your young people. And, it's like the sex talk. It sucks, but you got to do it and be really honest, right? I think Dr. Johnson was talking about um, marijuana being everywhere. And that literally did happen at my kid's school, right? Where they're like, and like the parents were like, don't touch my brownies. The kid's going to touch your brownies, right? And then they brought him to school and things ensued. But it's like, this is what marijuana is. You can't have it be the auditor people in the auditorium. They had folks in the auditorium at my daughter's school, and they're like, this person had one cigarette of marijuana and now they are paralyzed. Like, no more of that nonsense, right? Like, be honest. Be honest about some of the dangers. Like, okay, so if you say you want to use marijuana, I need you to know that while your brain is growing, it's going to have a huge impact, right? These are things. But if you do use marijuana, I want you to come to me. I'm not going to take you out. I'm not going to be ashamed. Like, so some of those conversations we need to recognize, and Dr. Johnson said this about everyone, but like that self-esteem building. Kids want to be seen, heard, loved. Kids want gym. They want, it's really hard to sit for 8 hours a day. Give them a chance to get up. I had this one kid and he's like, I just want a job. So it's like we actually put barriers in the way before people use substances. Even in Baltimore, a lot of the kids were selling drugs before they were using them for income, right? It wasn't about they had a substance use disorder. Like, how is that? So you create jobs, right? A lot of this is kind of no nonsense. And that helps the family. It helps build the kids' self-esteem. It helps the kids see their love, not just by parents, because there's a period during adolescence where kids are supposed to distance and they're not listening to anything their parents have to say, right? Where there's other adults that kids trust. It is not, people are like, well, they just go to school. Schools are not welcoming for everyone, right? I am like always up in my daughter's school wearing them out. And so, like, what does it look like for the other trusted adults and supporting them to have after school activities? And so I think just being there, one, getting rid of some of the crap that we put on kids, like not being sick for 8 hours, but then also realizing this is where mental health comes in, is it's hard. Also, we should have services. We don't enough, but we should have services for families, right? So if you're really frustrated and you want to talk to someone else, we have Al-Anon, but there should be a place where you can go and get your own mental health and get your own feelings in order, even if it's anger, if it's whatever, to come back and embrace your loved one. Because at the end of the day, even if folks are frustrated, they love that person, right? For the most part. So, how do you make it so you're not vilifying the family, you're not vilifying the kid, but you're admitting that sometimes there's friction and you're allowing the spaces where folks can grow. But I do think we do need to do a better job at prevention and including families in that prevention work, writ large, and it would help not only prevent substance use, right? But it actually helps to create a relationship, positive relationships that's going to help with the mental health, going to help with the sex, going to help with the substance use, help with the school, right? So I as a pediatrician, I would put a plea in for starting early.
Yeah, and thank you for that. And I think, Lydia, it's also important just to build on what Dr. Taylor said is families have to be educated. There are a lot of programs that are not designed historically to have like family therapy, family support. And that's one of the sad things about addiction is that like here in the Detroit area, the average age of people entering treatment is about 35 to 40 years old. And most of them, it's a lonely process. They burn bridges with their families. And again, we're already dealing with this shameful, painful disease because families are impacted, they're affected emotionally. And I think we don't, so when we talk about health equity, I think we don't put enough into early intervention, prevention, as well as treatment and recovery support for the family members. Because it's a slippery slope when you have family members that enable the person who's actively using. And they don't always know the difference between enabling guilt and love. And so I think it's a lot to really unpack there, just psychologically around what's going on with that family unit. But it's also a lot of healing that needs to occur between the person who is in recovery and their family. I mean, I had the fortunate personal experience of I got sober at 18, and me and my mother later, became best friends because, but she taught me right from wrong, but I just was more. I was that person you talked about earlier that was trying to sell drugs and ended up becoming my best customer. And actually, when that changed, then when the recovery came, then everything else got better. Relationships with parents, but now we're in a new day, and people have burned bridges. Their parents are deceased, so that's a lot of healing, a lot of grief. Now we're in a day where it's a lot of family trauma, intergenerational trauma, right? And that has to be treated with the right trained therapists and staff. And then the bigger picture for me is we just got to look at the disease of addiction like we look at any other illness. And I think when we begin to shift gears and destigmatize addiction, the better off we can talk about it, and we can talk about how do we develop practical solutions. We can talk about how do we develop more policies that's ultimately going to help build a more equitable system to ensure that everybody get what they need. Everybody have the access they need. Everybody should have access to treatment on demand. We should not have treatment waiting lists in America. And we know that people are dying every day, every second. I mean, when we look at the history, excuse me, and I think you did a really good job touching on some of the historical aspect, Dr. Taylor, around just the intersection between incarceration and drug use. We know about the mandatory minimum when these young boys were 19 and 20 in the early 90s and the late 80s during the crack epidemic, getting 30 years of their lives versus, if you were the man somewhere in Colombia and you got caught with some powder, you may get a couple years. I mean, it's outrageous. But we also know that our prison population has significantly grown throughout the country, and we have the highest number of individuals incarcerated in America than the rest of the world. That has become the new business. So it's so many other aspects I think that we can tie into substance use disorder. But I think community education, early intervention for families, for kids, perhaps even have them an important component in our inner city schools, elementary, middle school, high school. And then, just developing emotional and coping and social skills are important. And I think, unfortunately, we have young kids that come from households where parents are actively using drugs and alcohol. Those kids are more susceptible to trauma, being traumatized and scoring low on the adverse childhood piece of paper, the ACEs, right? And so we have to counter all of that. And we have this information, but we don't have enough resources to support. And that's why we need people like you who represent the National Urban League to say, hey, we need to change, we need to move the needle. We got to change the narrative and we got to be more effective with making a difference in Black communities.
Mm-hmm.
Can I just add a little piece to Lydia? Because, and I know this is going to sound pie in the sky, but it gets to that destigmatization. You can't see me because I'm just head up, but I've never met a baked good that I don't like. And I need to lose some weight. And, it goes along that idea. Now everyone's on Ozempic. And that's a medication that's going to decrease your cravings so that you could be healthier. No one's like, I'm not talking to you because you use Ozempic. Everyone's trying to get it. Insurance companies are trying to cover it. When there was a difficulty getting access, they allowed people to do it off label for his and hers and all that stuff, right? And
Mhm.
just think of that difference. It really is about, I'll use I language, right? When I get stressed, I eat. And that was recognized. It wasn't like Kima is a horrible person. I'm not on Ozempic. I probably should be, but that's a whole other thing. They weren't like Kima's a horrible person. We are going to make sure you never have access to the things you need that can make you well. But that's what we do to substance users. So that stigma, and we call it stigma, it is stigma on one level, but there's also a deep race dynamic. Because when this new epidemic came along, there were certain people that had access to those services and certain people that didn't. And we focus so much on the stigma that we ignore the racism, and that's why our overdoses deaths are still up. And that gets me to something even more fundamental with the Urban League. We have to stop, our society has to stop doing all the things that are stressing people out, stressing Black communities out. We need to stop being racist. We need to not it's not, people don't use drugs because they want to harm anyone. They want, like, right? It's like sometimes people are using because it makes you feel better.
Mm.
Sometimes you're using it because you need a job. Why are there no jobs? Whether you have a record or not, there are no jobs for young Black men. Like that, we have societal problems that have created much of this. And then we as the Black community have bought into the you're not, the stigmatization, the hostility, the ostracization. Like, so, and then we're like, and then we're going to make sure there's no services available, that you can't pay for it. This administration is coming in and saying, we are going to recriminalize you and make sure you don't have access to services. Like, there's some deep rot that we are throwing on top of substance use and making it worse, but it would also help families and our loved ones if you got rid of the deep rot, right?
Well, you kind of
Mm.
just led me to the next question. So we have about 10 minutes. I'll just say if anybody has a question, please make sure you put it in the question and answer function of the chat. But the question I was going to ask is actually this issue of decriminalization, of policy, of how we've treated. Both of you talked about the crack cocaine epidemic in the 80s and 90s, and as a child of the 80s and 90s, I remember it. And right there wasn't the thing that was gonna. I lived in Brooklyn, New York, so I'm just gonna say just right there. And so I saw all sorts of things, right? And the interesting part is, how we criminalized crack cocaine epidemic compared to the opioid epidemic. I had people coming to me, which is like, I don't get it. And I said exactly what you said, Kima, was it's racism, right? The opioid epidemic is affecting white people in a different way. And therefore, now we have all these solutions. But the crack cocaine epidemic was affecting mostly, not that there wasn't plenty of white folks taking crack cocaine, but it was mostly hitting inner cities with Black populations. And so we made it criminal instead of saying, what are the solutions, which is exactly what both of you said. You both used the term that people who listen to these webinars are probably tired of me saying it, but I say social determinants every single webinar because it's important. I base this webinar on the social determinants of health because it is true. If people do not have jobs, and it's easier to sell drugs than it is to find a job in the neighborhood, they're going to sell drugs because they have to feed their families. Period. End of stories. Because as Andre said, as Kima said, people just want to support their families, right? They just want to have food, they want to have housing, they want to have shelter, they want to have the latest kicks. That's true. We all want the latest kicks. I want the latest Jordans, right? How do I get that? If I cannot get a job, if the school system has failed me, right? Or I got incarcerated for something very minor and now people want to employ me, how am I supposed to make money to support myself or my family? right? To get access to health care, to be able to pay to go to a doctor, to be able to pay to do any, to send my kids to school, to all those other things. So how do we think about policy around around substance uh, use disorder and the social determinants, right? Like what do we, because whatever, we just said it, it's racism. We're not going to get rid of racism, especially in this administration. So what can we do? I'm trying, I always, this group knows I always try to get us with hope, right? What can we do even in this administration to support members of our communities who are dealing with this issue?
Yeah, I think it's a lot to be done, and we got to learn from our past. Just thinking about this whole opioid epidemic and how movies came out as a result of suburban white kids dying. White folks was at Congress talking about the impact that opioid has had in their community, and I don't think we've done historically a good job representing our inner cities in Congress and demanding that resources are there to help support people who are struggling with addiction. It's still the pink elephant in the living room. Politicians, we need more Black politicians to start talking about what are you doing around addiction and how do we improve and make sure that treatment, prevention, and recovery services are available in our communities. I mean, and like you said, Lydia, back in the day, we didn't grow up with, and I don't know how old you are. I might be older or younger than you. I don't know. But, we didn't grow up playing the Xbox for 10 hours a day. We had gym activities, we had playground activities, we had, sports activity, and, things have changed. Playgrounds are non-existent now. Playgrounds are not safe now. We're talking, and, Kimá, she talked a little bit about the economics of all this stuff. It's so much that goes into this in terms of one, making sure that we have the resources to have alternatives for our kids in our community, but when you're talking about social determinants of health, we're talking about an inequitable system. And the intersection that impacts substance use disorder and mental health is housing, it's education, and it's employment opportunity. Quality of life are impacted by all these variables. And so for us and me, it's important again to make sure that this body knows we all have responsibility for our community. We have the responsibility to advocate. We have the responsibility to support, open our doors up where we can have 12-step meetings, 12-step Narcotics Anonymous, 12-step Alcoholic Anonymous. In here in Detroit area, these people were dying, and we had judges and successful people created an organization called Families Against Narcotics and called FAN, and they started coming together talking about their grief from the loss of their children who were overdosing and dying. And now they've become a big nonprofit in our region. And so I think, again, we just really need to learn from the past. And I just think we did a horrible job during the crack epidemic. I mean, like you talked about what was happening in Brooklyn. I saw what was happening in Detroit, the neighborhood I grew up in, where it was, a house on, now it's 3 houses on the block versus 25 houses on the block. We watched the devastation of communities, and now we're watching the communities be gentrified. But nothing was done for us. But also, again, I take some of the onus that we didn't step up and say, not in my backyard. We didn't take the NIMBY approach. We didn't advocate for our communities. We do not even feel safe in our community. So it's a lot. And again, I don't want to necessarily place the blame game, but I do want to say we got to learn from our past and do something different.
Yeah, I agree with everything Dr. Johnson said. And even around, and someone put in, I took the liberty of looking Q&A, but even around language, right? And one, I am always actually a little afraid of using behavioral health, because what happens is then people really mean mental health and they ignore substance use, right? And because it's scary. And so we need to put substance use on the table and truly advocate. But I do think that requires the Black community sit down and have honest conversations about that. We have really bought into that stigma and shame and embarrassment in a way that is literally killing people. And as a result, our policymakers aren't talking about it. They're putting out things about young male suicide. They're putting out things about and completely ignoring the substance use conversation, even when you try and push them. And so we need to hold folks accountable. Like, we are dying. You need to speak up and get money for us, right? And make it sustainable. And I do think it's a lot of, and we have to have conversations around language. Someone put in there, how come it's the opioid crisis and the crack epidemic? And partly it's funny because a lot of Black people pushed back against that epidemic phase because we called it the prescription drug epidemic. And it was like, well, not everyone's using prescription drugs. So then it became prescription drug crisis, but then they took it over to the opioid crisis, right? I think we have to tell our own narrative. We follow their language, their narratives. I was on one call and someone I called myself a Black woman, and this other person who was not of my hue was like, "You're actually African American." And I was like, anyways, but right, even in this space, we do the same thing of, if you don't use the right language, you're off the table. If you don't have the right, pedigree, you can only talk in something. Like, we need to get our ish together. We got to start advocating, but we got to create the solidarity so we can advocate together, so we can reclaim. I mean, these are our tax dollars. I don't pay as much as some, but well, probably because they're not paying any taxes. But anyways, these are our tax dollars. They should be going to our communities to be utilized in order to improve our communities. So we got to get out there and know it's not fair. As Dr. Johnson said, I don't want to play the blame game, but they are not going to come help us. So we got to get out there and take what's ours, and do it well as he is.
Let me give you a quick scenario. I talked to one of my directors earlier, and I asked her. She directs our program where we conduct expert services, screening, brief intervention, referral treatment, where we use this tool to see what kids complete this tool. It's a self-disclosed tool, and I said, well, out of the kids, and we target kids between the ages of 13 and 18 years old, and we've had 160 screenings. And I said, so out of those screenings, give me the data around what's going on. Well, she said 75% of them are using. They self-disclose using. And I said, well, what are they primarily using? They're vaping and they're using marijuana. And I say, so we have to use this information to inform us around how do we message, develop new messages. So instead, so let's do something on social media. Let's do something on the radio. Let's do something in the schools. Let's build some campaigns, some anti-campaigns around vaping in the Black community and marijuana uses in the Black community. We know this stuff is more prevalent now than ever. And so one is, I think, when we talk about health equity, we got to talk about data. We don't collect data. All we talk about is number of people incarcerated, which is not a bad thing, but we don't talk about the things that contribute to incarceration, like substance use disorder and selling drugs and addiction. And then we have to talk about, as Dr. Taylor said, we need the government, the politicians, to ensure that we have money going into these areas of prevention and early intervention. Because if we can't save them as young people, then it's going to cost us more later in life treating them as adults, especially in the prison system. I was just reading something where they said an average inmate that spends 365 days a year in the county jail in New York costs around $500,000 a year. So now we're talking about, we need to really just ensure that we're addressing these issues. So we got a couple tracks. We got the prevention, which is important and significantly underfunded. Then we have treatment, which is a small aspect in terms of the cost of that, and making sure that those are available for those who are ready on demand. And then we got recovery. We want to be able to help people sustain their recovery, so we got to have resources to continue to provide all those services.
Well, I think actually we're going to end on that note because that was actually fantastic.
Okay.
And we are over time, so I want to respect people's time. But I will also say that maybe instead of bombing people in boats off to Venezuela, we should be sending the money to community-based organizations like yours.
And bailing out Argentina, like, really?
Yeah.
Sorry.
That's okay.
That's a
And,
fact.
and to working on education programs like you said, Dr. Taylor. Thank you both. This was phenomenal. I learned so much. There's things I didn't actually know. So I really appreciate it. I'm sure you will hear from some of our affiliates and other folks who are going to be interested in talking to you further about this. But thank you. We will continue this conversation hopefully at some other time and talk more about this issue. But this was an important issue for us to talk through for the National Urban League on our health equity webinar. And I just am immensely grateful that you all took the time out of your busy schedules to be with us. Thank you, everybody. See you all
Thank
next month.
you.
Have a great day.